Welcome to the Mountain West AETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Welcome everybody, a very exciting session for Mountain West AETC ECHO. I'm really looking forward to it. And first, I'd like to extend a huge welcome to Dr. Bob Rokita. Thank you for joining us today. Dr. Rokita is clinical professor in the Department of Medicine here and is one of our experts in organ transplant. And Bob's going to talk about a very exciting subject. So thank you for doing this, Bob, and I'll turn it over to you.
Thank you very much. Thanks for having me. So I'm going to talk briefly about solid organ transplantation in HIV, and I'm going to give you some of the background, particularly a lot of information about transplantation first, and then talking a little bit about how transplant is interacting with HIV and how things are going, and hopefully if you have questions afterwards, feel free to ask. So as you are all aware, HIV is now a chronic disease, and so a lot of chronic medical problems have become more and more prominent. And some of the areas that we would be particularly interested in thinking about solid organ transplantation might be kidneys and livers and hearts. So in terms of chronic kidney disease, there are about 1% to 2% of HIV positive folks in the United States with end-stage renal disease, and typically these are from a variety of different causes, but most commonly HIV-associated nephropathy with collapsing FSGS or immune complex-mediated glomerulonephritis of various types. And you can also get a hepatitis C-associated MPGN. In terms of liver disease, by far the most common is related to hepatitis C, but there are others. There's a significant co-infection rate, of course. Hepatitis B, not as much in the US, but in other parts of the world, more prominent. And just like in the non-HIV population, hepatic steatosis is increasing significantly in terms of causes of end-stage liver disease. In HIV, occasionally it can be due to drug toxicity. Rarely, patients are still on some of the older agents, such as D4T and DDI. And every once in a while, it's thought to be related to efavirenz. In terms of heart disease, of course, there's ever-increasing coronary disease in HIV as well, with dyslipidemias, both related to the HIV and to antiretroviral therapies. So now a little bit of background about transplants. So this is just to show you kind of what the transplant situation overall looks like in the US. On the left-hand side, you'll see numbers of patients that are on the waiting list for different organ transplants. And in the top line up here, so these are kidney transplants, and for the last year in 2014, you can see there are about 60,000 people that are awaiting kidney transplants that are already listed. On the other hand, on the right side, you see the number of transplants that are actually done, and you'll see that there are about 17,000 kidney transplants done per year. So there's a significant discrepancy between those two numbers. A lot of people who need kidneys do not get them, and the same is true for every single organ. So here's the numbers for livers, with about 12,000 folks on the waiting list for a liver and about 6,000 that are done, and the same is true for others. So heart is down here. Ever increasing numbers of heart patients that are listed. There are an increase in the number of heart transplants that are done every year, but it does not keep up. So a lot of folks who need organs who don't get them or who wait a long time to get them. Average wait list for kidneys depends on a lot of factors, but in the Pacific Northwest can be 3, 4, 5 years before you get one. So again, some background about transplantation. There are a number of immunosuppressive drugs that are used, and really this is critical. So in the old days, solid organ transplants did not work. And the reason was because of rejection. The field was really revolutionized by the development of cyclosporin. And cyclosporin was developed by a couple of folks, Jean Borel, who synthesized it, and Roy Cullen, who is one of the transplant surgeons in England, who promoted its use. And that revolutionized the field of transplant because now both graft and patient survival rates skyrocketed. So here's a list of a variety of the most common drugs that are used for immunosuppression in this population. There are calcineurin inhibitors, and the most common that's used now is tacrolimus. Cyclosporin is not used nearly as much, but every once in a while it gets used instead because of a particular toxicity. There are cell cycle inhibitors. The most common that's used is mycophenolate. Azathioprine is used sometimes. Corticosteroids, of course, are used a lot. And then there are mammalian-targeted rapamycin or mTOR inhibitors, the most common of which is sirolimus, or as it used to be called, rapamycin, and everolimus. In addition, many transplant patients will receive induction immunosuppression at the time of transplant, and that can be for a couple of different things. One can be they can get lymphocyte depletion therapy with anti-thymocyte globulin, or ATG, or with Campath. Or they may receive a basiliximab, which is an anti-CD25 monoclonal. And all these, of course, have different mechanisms of actions and different toxicities, and also different interactions, which we'll get to in a second. So in the old days, there were a number of small attempts to do solid organ transplant, primarily kidney transplants in HIV, and they did very poorly. And this was because HIV patients did very poorly. And so as the advent of antiretroviral therapy progressed and patients did better and better, the idea was that maybe this was actually a reasonable thing to do. So a multi-center trial was done, and the results for kidneys were published in the New England Journal in 2010. And the results were striking. So what they found was that in HIV-positive folks, both graft survival, kidney survival, and patient survival was quite good. And these folks were very smart, so they a priori did the trial set up to compare not only to the global overall population, but they also took another population to compare it to, and that was to folks who were transplanted who were over age 65. And they realized that it is a given that folks over age 65 are okay to transplant, so they said, well, if they do as well as these folks, then that would be reasonable, and in fact, they did better than that. The findings were that the overall study showed there were risks for worse graft survival with rejection, and interestingly with ATG use, but which was not confirmed in later studies, that there were markedly higher rates of rejection in the HIV population, which has been confirmed, and maybe that may be due to drug interactions. There's a prolonged decrease in CD4 counts after you use ATG, which may or may not lead to any significant problems. There was a higher infection rate after ATG, which has not been confirmed in later studies. Actually, most places now use ATG as a standard induction regimen. And the most important thing is there's no progression of HIV viremia or worse opportunistic infections. The other things to note is that survival is higher in HIV-positive kidney transplant recipients compared to those folks who remain on dialysis. This is true for non-HIV and is similarly true for HIV. So it's better to transplant people than to have them stay on dialysis. The other thing that was interesting is that a disproportionate percent of patients with HIV are listed for kidney transplant. They are listed far fewer numbers, 17% versus 62% for HIV negative, and this is not because they have a low CD4 count or because their viral load is not suppressed. Only 20% are related to that. So there are other reasons related to them not being listed. In addition to the non-HIV criteria, which there are a bunch of them to be listed for transplant, there are certain things that are specific for HIV. And so for us, we use the same protocol that was used in the multi-center trial, basically that you have to have been on a stable antiretroviral regimen for 6 months. You have to have a non-detectable viral load. Your CD4 count has to be greater than 200, or for liver transplants, greater than 100. And that's because their total lymphocyte counts in end-stage liver disease are lower. If you have a prior opportunistic infection, you can't have had one for a year, and there are several other exclusions that are listed there, including a variety of cancers. And you can see all those unless they have been cured and have done well for several years. We are not retransplanting patients, so if they have failed a transplant, they don't get another one. And if they are highly immunoreactive against HLA types, that's what the PRA means, we are in general not transplanting them. There are exceptions, but that's just because there's a higher rate of rejection to begin with, and so this would indicate there would probably be a significantly higher rate of rejection, even more so than that. In the experience so far at the UW, we've done 10 kidney transplants. One has had severe late rejection. He got very depressed. He stopped taking his meds. He lost his graft. Not much to do about that. There are 2 who've had mild treated rejection. and creatinines in the mid-1s. There are 7 who've had no rejection, and we still have a few that are listed. So overall, reasonably good outcomes, and basically similar to what the multi-center trial showed. So getting back to drug interactions, I think this is one of the keys for the HIV positive population. So I've listed this as good and bad, not because they're good or bad drugs, but in terms of how they interact with immunosuppressives, particularly calcineurin inhibitors like tacrolimus. So the nucleosides have very little interaction. The entities have little interaction. CCR5 antagonist has little interaction. Rilpivirine as well. But if you're going to use that, you have to remember that it needs acid for absorption. And around the time of transplant, most of these folks get PPIs when they get a lot of steroids. So that can be a bit of an issue. So basically, the ones that we are concerned about are any boosted regimen. So the ones that have either ritonavir or cobicistat have lots of drug interactions with azoles, calcium blocker statins, but in particular calcineurin inhibitors. And you use them with a protease inhibitor boosted regimen, you end up using a very, very small dose. So for example, if we were using in a normal patient 2 to 3 milligrams twice a day, we might use half a milligram of calcineurin inhibitor once or twice a week instead. And that may be significant because that may be a reason why we don't have the same ability to prevent rejection, maybe due to the drug interactions. The same finding is true for mTOR inhibitor, sirolimus. Other things are variable. So for the non-nukes, efavirenz does reduce calcineurin inhibitor levels, etravirine a little bit less so. So what do? Well, we try to find a regimen that will not interact. If possible, we do this before transplant. We should not be changing the regimen at the time of transplant. You know, a lot of these folks are heavily pretreated. They have lots of resistance mutations. So if you can't find a regimen that doesn't interact, well, that's just the way it is. And we'll deal with the dosing changes afterwards and follow closely. But if we can, we try. And I put this up here just to remember that dolutegravir also may artifactually increase the creatinine. So for kidney transplant folks, sometimes the nephrologists get very worried about that, and we have to reassure them that that's okay. That's probably not a problem with the graft itself. In terms of liver transplant, again, multi-center trial was done. Results came out a little bit later. It revealed 2 distinct populations, one that's hep C positive, one that's hep C negative. For the hep C negative patients, these were basically similar outcomes to the non-HIV population. This included patients with hepatitis B. They did really quite well. The hepatitis C patients did significantly worse. There was a subgroup that did not do worse. But you have to realize that, again, all of this is prior to the new directly acting agents. So basically, I think all of this is probably irrelevant. They're listed here what the 3-year graft survival was in this study that was published in 2012, 53% for the co-infected patients versus 74% for hep C alone. But again, I think that the numbers are probably going to trend to the same as what they would be for the non-HIV population. In terms of other organs, there have been a relatively small number of heart transplants in HIV that have been done. The outcomes have been good. We listed one patient here at the UW. They ended up dying from something else prior to transplant. We have others that are being evaluated. There have been very few lung transplants that have been described. There have been a number of ventricular assist device patients who have gotten VADs that are HIV positive, have been described and have done quite well. So that should not be a limitation. And lastly, just to talk briefly about HIV positive to positive transplants. So this was first described from South Africa, where dialysis is not nearly as much an option. Their original report came out in 2010 of 4 recipients, 2 donors, who had not received any antiretroviral therapy, no OIs, no proteinuria, normal renal biopsies. They did well. And the follow-up report came out in 2015 with 27 patients with a 3 to 5 year follow-up. The donors could have been on first-line antiretrovirals. They had to have a non-detectable viral load if that was the case. There were some exclusions, including TB and AIDS. The recipients couldn't have any opportunistic infections, and if they had had TB, they had to have been treated for 6 months. And there was a requirement for lifelong prophylaxis with Bactrim, which we actually do as well, and interestingly with INH there. And they used ATG induction, and their outcomes were excellent and basically the same as in the HIV negative population. So until a few years ago, this was illegal in the United States to use an HIV positive donor. The HOPE Act was signed. And then it has taken a little while for this to wend its way through, but now Hope in Action, well named, is ongoing, and there is a study of the donor landscape looking at the organ procurement organizations to look at the epidemiology and biology of a number of HIV-positive deceased donors, looking at the organ quality and the amount of resistance that's present. There's a pilot recipient study which is ongoing, looking at kidney transplantations, and the multi-center trial is probably going to start this year. Later on, it's not clear. We hope we will be part of that, but has not been finalized yet for both kidneys and livers. So just to summarize, I think, as you know, HIV chronic disease, a lot of kidney, liver, and heart disease. Kidney transplant has very good outcomes, higher rates of rejection, which can be managed. Liver transplant has very good outcomes if you are not hepatitis C positive. I think that's going to change, and it will be the same. Drug interactions are a major issue, and so have to be thought about ahead of time and actively managed, and positive to positive transplants are on the horizon. That's it.